The recurrence score was originally developed for ER positive patients that were lymph node negative. And after that data came out and it showed that it was extremely robust and other studies showed the same type of information, oncologists and researchers started thinking, well, maybe we can utilize this test in node positive patients. So we're getting a lot of great information for node negative patients, but can we actually use it in node positive patients? Could there be a group of women that are estrogen receptor positive and node positive that would not benefit from the addition of chemotherapy? So originally there was a really great trial called SWOG 8814, which looked at node positive patients. And in this retrospective prospective analysis, it did show for postmenopausal women that there was no benefit of the addition of chemotherapy for women that had a recurrence score less than 18. So this gave us information that we could potentially use this in postmenopausal patients with maybe a small tumor burden in the lymph nodes, maybe a micrometastasis or one positive node, but it was really limited data. There was also some data from the trans-ATAC trial looking at node positive patients and showing that women that had 1 to 3 positive nodes that got hormone therapy alone that were postmenopausal actually had very good outcomes. So again, this added to the information that maybe there are women, specifically in the postmenopausal setting, that would not benefit from the addition of chemotherapy. So I think oncologists across the country started incorporating this data into their postmenopausal patients. Now recently at the San Antonio Breast Conference this past year, there was a poster presentation looking at premenopausal or women under the age of 50 with node positive breast cancer that were ER positive that also had the oncotype recurrence score. Now this was presented in poster presentation and it was from the SEER data, which has a very large number of women. So we're talking about large data sets here, over thousands, thousands of women. And what this data showed is that even women that are under the age of 50 that have either micrometastases or one positive lymph node, if they didn't get chemotherapy, they actually did very well. So again, this adds to the body of evidence that the recurrence score can be used for node positive patients. And specifically now, we can start looking at premenopausal or women under the age of 50 in these patients that have one positive node or micrometastases. So we can potentially now take away that over-treatment they were getting with chemotherapy, but really use it on an individualized based, discussion and multidisciplinary tumor board discussion to look at these patients. Now, for this, is it changing practice? I think it is. In our own clinic, we are definitely identifying women that are under the age of 50, that if they have a micrometastasis or a single positive node, our oncologists feel more comfortable ordering the recurrence score, looking at the number, and helping identify potentially patients that can forego chemotherapy and just get endocrine therapy alone. So it really is great for these women as well.